Hi, good afternoon. My name is Bob Blancato, and I am the national coordinator of the Defeat Malnutrition Today coalition. And I'm delighted to be part of this wonderful webinar done in conjunction with the John A. Hartford Foundation, with our title of the day being Building Age-Friendly Hospitals, the Role of Nutrition Care. Next slide. So let me briefly go over the agenda before I turn the program over to Laura. I'm doing the hello and welcome, if you can tell. And we are very pleased that you're here for this important discussion. We're going to provide a background on the issue of older adult malnutrition, something in which our coalition has spent a number of years focusing on, trying to get policy changes made to get awareness raised and so on. And then we're going to talk about the very important age-friendly hospital measure that was originated through John A. Hartford Foundation, now is being implemented in hospitals across the country, and malnutrition screening within the context of the age-friendly hospital measure. And then we're delighted to have two colleagues from Grady Hospital in Atlanta to give us some examples of how it all works. And then we'll go to questions and answers. So without further ado, let me turn the program over to our wonderful policy director for the Defeat Malnutrition Today coalition, Laura Borth.
Hi, everyone. Welcome. We hope you leave here today with a better understanding of this measure and how it ties to other CMS quality measures, as well as where nutrition and malnutrition fit in and how we connect it all back to the community. I am one of your hosts and moderators, Laura. I'm a registered dietitian and the policy director for Defeat Malnutrition Today. You've already met Bob Blancato, our esteemed national coordinator of DMT and the executive director of the National Association of Nutrition and Aging Services Programs, or NANASP. Dr. Cheryl Phillips, senior program consultant at the John A. Hartford Foundation, will walk us through the measure. And finally, we will hear some practical examples from Dr. O, professor of medicine at Emory University and chief of geriatrics at Grady Health System, and Danielle Spellfogel, clinical dietitian supervisor at Grady Health System. So just for a brief background, Defeat Malnutrition Today, we are a coalition of over 130 national, state, and local stakeholders. And we're working towards creating policy change towards a greater emphasis on screening for, detecting, treating, and preventing malnutrition. So as many who are attending this webinar today are probably aware, malnutrition is an underdiagnosed issue, costing billions of dollars every year in disease-associated issues. An estimated 20 to 50% of hospital patients are at risk for malnutrition, but at least until recently, malnutrition has only been diagnosed in less than 9% of hospital patients. And so it is flying under the radar of care in the United States. But with the age-friendly hospital measure and the global malnutrition composite score measure, we're starting to address this. People may ask, why start in the hospital? Why is this where malnutrition should be diagnosed? And for many, especially in at-risk communities, the hospital is the primary healthcare service. And as you'll see in today's presentation, hospitals have the infrastructure, workflow, and trained clinicians who are ready to conduct these screenings. Malnutrition can be identified at the time of hospital admission, and it is easy to refer patients to the appropriate professionals, improving access to their needed care and timely follow-up. Hospitals can also monitor interventions for better outcomes, and what starts in the hospital can be continued at home. And to that end, there's a big importance of connecting these hospital measures to community-based organizations. This is critical to preventing readmission of those diagnosed with malnutrition. And not only does it save healthcare dollars, it also, helps hospitals from being penalized for readmission rates. And it adds new relevance to the existing network of community-based nutrition programs, especially, in the older adult space, the senior meal providers and area agencies on aging who are equipped to help fulfill the nutrition needs and other needs of older adults in the community. We wanted to briefly touch on another CMS hospital quality measure, the Global Malnutrition Composite Score measure. This was the first nutrition-focused clinical quality measure in the CMS reporting program. And reporting for those 65 and older started in FY25, so last October. And this has been expanded to those 18 and older starting in FY26. And this measure focuses on the 4 steps of screening for, assessing, documenting, and developing a nutrition care plan. And so this can really dovetail into the age-friendly hospital measure. And with that, I will turn it over to Cheryl.
Well, thank you so much, Laura, and thank you for this opportunity. And I will say, as a geriatrician, the intersection of malnutrition and nutrition as health is so fundamentally important. I want to spend just a little bit of time giving you some background. We can go to the next slide. I'll go through these quickly to the John A. Hartford Foundation so that we understand where the John A. Hartford Foundation began and how they became involved in this measurement process. The John A. Hartford Foundation is a private philanthropy. It was actually formed from the family of the A&P grocery store back in 1929. And since the early 1980s, the John A. Hartford Foundation has now contributed more than $800 million to improve care for older adults. Next slide. And the priority areas that you will see, and there's an intersection, and all of us that provide care for older adults understand this intersection very well. Age-friendly health systems, and we'll talk about the measures, serious illness and end-of-life care, as well as family caregiving. Next slide. So we're going to talk first about the age-friendly health systems that began in 2016 in partnership with the Institute for Healthcare Improvement, IHI, the American Hospital Association, AHA, the Catholic Hospital Association, and of course the John A. Hartford Foundation. These 4 elements, called the 4 M's, are in some ways very simplistic, but they're evidence-based and they're really at the core of what matters in care, not just what matters to the person, but what matters in care for older adults. Now, many people have talked about adding additional M's, whether it is multimorbidity, whether it is malnutrition. But as we look at the evidence, we think that all of these other areas really fit well under the existing 4 M's. And you'll hear a little bit more, not only in my examples, but most importantly in the hospital examples. Next slide. So as we've mentioned, why the 4 M's? Core issues built on strong evidence. They're easy to measure and they're synergistic. They relate to one another in so many important ways. And we could go through multiple examples of how each of the 4 M's of what matters, medication, mentation, and mobility, intersect in optimizing care for older adults. Next slide. It is a growing movement. This slide actually is delightfully a little bit outdated. There are now over 5,000 sites of care that are committed to age-friendly approach to care. We're also expanding into ambulatory settings, specialty practices, primary care practices, home care, looking at the continuum of the individual experience. There's also work that's done in age-friendly communities and age-friendly ecosystems, and we're even beginning work with age-friendly health plans. Next slide. So we looked at how the 4 M's apply into hospital care, and you can see this example. I won't read it for you. Starting with what matters, aligning the care plan with the individual and their goals, not just their overall healthcare goals, but their goals even for this hospitalization or for today. Looking at high risk medication use, deprescribing those which are inappropriate, but also making sure that appropriate and optimal medications are being used. Screening for delirium under mentation, a critical issue for the hospital. You can see all of the interventions, as well as screening for mobility, which is very different than falls prevention. Very often at a facility level, we're focused on our surplus of safety. We don't want people to fall, so we make them immobile. When in fact, our best approach is screening for mobility and ensuring early and safe mobility, which ultimately ends up reducing fall risk. Next slide. If you want more information about the age-friendly health systems movement, here's some wonderful resources. They are all free. There are calls to integrate. There are ways to engage your organization. And I encourage you to look at these websites. And if you have any questions, you can even reach out to me directly. So now let's move specifically into the hospital measures. The hospital measures, and this is a QR code to give you much more information about it. The CMS moved with the help of our geriatric surgery validation group to have the CMS age-friendly hospital measure group. They're built on the 4Ms, and there are 5 domains. They are based on self-report attestation. There will be random audits, so the hospitals are concerned about making sure they do things correctly. And there is a pay for reporting, in that it's built around the hospital inpatient quality reporting program. So they're not required to do it, but they will leave money on the table if they don't. Next slide. These are the domains. I know that it's very difficult to read, but the domains are eliciting patient healthcare goals aligned with what matters. Domain 2, responsible medication management, again, aligning with the medication M. Domain 3, which we'll spend a little bit more time talking about, frailty screening and intervention, which includes mobility and mentation, but also screening for malnutrition. Domain 4 is a social vulnerability, which is also critical for individuals once they return back into the community. And we know that social isolation is a huge risk factor for older adults. And then the 5th domain is really to sustain and maintain these measures, and that is age-friendly care leadership within the hospital system. Let's go to the next slide, and we'll talk a little bit more about the hospital screening on malnutrition. So the important question tied to delirium, physical function and mobility is the early detection of malnutrition. And you'll see the attestation requirements. How are you screening? It's up to using your own validated tools, and we'll learn more about them. What are you doing for positive screens? What are you doing for tracking data and outcome? And what are the protocols as you apply them into the emergency room setting as well? Next slide. These are a couple of examples, and I'm going to go through them really quickly. Because we're going to hear very much from the Grady Hospital, and I don't want to take away any of their thunder. But Providence, for example, has given us some really important data on how they have integrated malnutrition, particularly for low income and vulnerable older adults, and how they also integrate it post discharge. I'm going to skip the next slide because that has to do with Grady Health, and we have some wonderful speakers who are going to tell us much more about Grady Health. But I want to go to the last slide, and that is thinking about malnutrition, but also nutrition. So we can go to the next slide. Nutrition in the context of the 4Ms. So yes, we want to screen explicitly for malnutrition, but I would also argue that nutrition both impacts and is impacted by all 4 of the M's. Under what matters, what are food preferences, what are choices about feeding methods, which are critical to the individual's goals of care. Under mentation, are they able to self-feed? Do they have alertness and the ability to swallow? For mobility, again, going back to self-feeding, can they sit upright? Are they able to position themselves for appropriate feeding? And the medication, such an intersection of medications and nutrition, both on the impact of taste, but also recognizing that medications may impact absorption of nutrients and may interfere um, what you're eating with some of your medications. So I included this slides that we think about not only the screening for malnutrition, but also understanding how nutrition is impacted and impacts all four of the M's. And with that, my closing slide is just a thank you and an acknowledgement. And feel free to reach out to me for any information that I can help with. And with that, I'm going to turn over to hear from our folks at Grady Hospital. Thank you.
Thank you so much, Dr. Phillips. So we'd like to share with you what we've been doing at Grady and how we incorporated malnutrition to become our fifth M. They're both of us, Yugochi, and I also have Danielle, and we'll be sharing our experience at Grady. Next slide, please. So just a little bit of a background. Grady is an academic safety net hospital that essentially cares for the underserved. It's the fifth largest public hospital nationally. Right now, Atlanta is considered to have one of the fastest aging populations in the nation. And so we play a key role in caring for older adults in Georgia and even nationwide. And so Grady right now has put processes in place to improve the care of older adults. It's also a level 1 trauma center. So right now we do a lot of geriatric trauma. And last year we opened up a surgical ACE unit, acute care for the elderly unit, all as a focus to improve the care of older adults, whether admitted to medicine or admitted to surgery. Next slide, please. So over the years, we've put processes in place to try to improve the care of older adults from the inpatient to the outpatient through transitions of care and then back to the emergency room. And so we've, put multiple care processes in place. In, I think, 2020, we became part of the age-friendly movement. And our focus was to implement the 4Ms framework within our health system. Currently, our inpatient is, right now we're designated to be, we're level 2, while both our outpatient and our nursing homes are level 1 in the age-friendly movement. An exciting thing for us is that our nursing home is the largest nursing home in the state, and they're about to add 100 more beds to, increase the capacity. So we see it as a great opportunity to improve the care of older adults in general, with what's going on at our health system. Next slide, please. So one of the things we've done over the years is to make sure that in implementing the age-friendly health systems, the 4Ms, that we aligned it with the organizational goals to make sure that we improve outcomes for older adults. And that has been a major focus for us. So whether it's mentation, mobility, medication, what matters, and we added 2 more M's, malnutrition and mild care transitions. We, try to make sure that those aligned with the goals of our organization and improve the outcomes for our patients. Next slide, please. So with the data, and one of the reasons why we felt that malnutrition was a major area for us to focus on and to add as a 5th M is the data on malnutrition, which is huge, and then even much more so at Grady. Next slide, please. You would see that over the last 3 years, we screened about 16,000 patients for malnutrition, and about 20% of them were malnourished. And the numbers are even much higher, next slide, amongst older adults. About 49% of our older adults were found to be malnourished. So this reinforced our efforts to make sure that we address that as part of what we're doing for our older adults. Next slide. And so it's, as both Laura and Dr. Phillips had shared, malnutrition amongst hospitalized patients is associated with increased mortality, increased hospital stay, length of stay in the hospital, increased discharge to long-term care facilities, increased need for home health services. So essentially, a lot of cost to the system. And so that was one of the reasons why we decided to focus on malnutrition, especially with our prevalence being so high amongst our patients. Next slide. And it's still saying, very high readmission rates, and, with CMS penalizing health systems for having higher readmission rates, that also informed our decision to make sure that we were addressing malnutrition amongst our patients. Next slide. So we added malnutrition as our 5th M, and part of what we did, and I'll have Danielle subsequently go into a little bit more details about this, was to make sure that using the Aspen guidelines, we had the nurses screening for malnutrition at intake. We had the dietitian also screening for malnutrition risk and food insecurity. We made sure that prior to discharge, we assessed the patient's nutritional needs and their access to food. And then we referred them to one of the community-based organizations that we had partnership with, Open Hand, and they would provide 2 meals a day for 30 days to those patients, amongst those patients that were found to be food insecure. Next slide, please. And so these slides show a little bit of what we did for the 4 M's, and including malnutrition and malcare transitions. Dr. Phillips has gone into details about the various 4 M's and how they are implemented. And so we implemented all those M's, including malnutrition. So we made sure we implemented it both in the inpatient, in the outpatient, and in the nursing home also. So this slide shows a little bit of what we do in the inpatient setting. The next slide shows, next slide, please, what we do in the outpatient setting, making sure that, just one slide back. So we do have, making sure that our patients, still an assessment of the patients in the outpatient setting. We refer those patients who are food insecure. It's part of our screenings when we see our patients in the outpatient setting, and then we refer them to Open Hand also. We also have a food pharmacy, and that, helps some degree of sustainability after the patients are discharged from the inpatient setting. Next slide. In the nursing home, screening for malnutrition still, and then, the dietitian in the nursing home making sure that that's addressed with the patients. And then from a nursing perspective, and the nursing assistants making sure the patient eats well and are well hydrated. Next slide. And I'll have Danielle begin to speak. Thank you.
Hi, everyone. My name is Danielle Spelfogel. I am the inpatient clinical dietitian supervisor here at Grady Health System, and I cover the age-friendly unit here at Grady. Thank you, Dr. O, for discussing the 5 M's. So I will go into detail about the 5th M for malnutrition and what we do at Grady. Geriatrics and malnutrition are topics that I'm very passionate about, and we make it a mission at Grady to address it. So as of 2024, CMS is adding an electronic clinical measure, clinical quality measure, which is the Global Malnutrition Composite Score that can be an option for the hospital inpatient quality reporting. It is the first ever nutrition-focused quality measure that will be tied to a hospital financial reimbursement from Medicare. Next slide, please. So to assist with this, Junum is a program that we have onboarded into our electronic medical record last year. This software assists hospitals in addressing malnutrition so they can maximize the value of the clinical teams, increase revenue, and help us deliver exceptional patient care. Our department has been working with Junum with their malnutrition CDS program that is EPIC compatible to allow us to organize and provide a key performance indicator, data-driven scorecard to track progress without malnutrition documentation. So we're able to report our response on Grady's malnutrition quality indicator, and we're able to report the GMCS to CMS. So when malnutrition is properly diagnosed and documented and coded, everyone is aware of the patient's nutritional status, which helps better manage the patient clinically, and reimbursements for the hospital can rise significantly. This takes everyone on the team working towards this goal, and that's why we're here today. Next slide, please. So as Laura mentioned, this is what the GMCS consists of. So here at Grady, like the nurses screen for malnutrition using the MSD screening tool, and then the dietitians screen all the patients on the floors, and we conduct the nutritional assessment. We document for malnutrition diagnoses and document the nutrition care plan as well. And then to get the GMCS score, the number of performed components divided by the clinical eligible denominators is what equals the GMCS. And basically at Grady, how we're assessing patients, the nurses are assessing using MST, which is assessing for weight loss and for PO intake. Then the nurses can put a consult in for patients so the dietitians can see them. But at the same time, the dietitians here at Grady, we cover most of the floors in the hospital. So we see our patients based on our own screening as well. We assess patients' nutritional needs and assess if they're food insecure as well on our initial assessments. We continuously monitor and follow up with the patients to ensure they are meeting nutritional needs during their admission. If patients are food insecure, we do provide them with food resources. So we do have a program that Dr. O was mentioning. It's with our community partner called Open Hand, and that delivers 2 meals a day for 1 month after discharge. We provide them with other resources that are local to Georgia and to Atlanta, as well as other available resources at the time as well we can provide to them. Next slide, please. So this is phase 1 of Junum. This is the malnutrition screen that is added into our flow sheets in our EMR. So Junum went live for us over 1 year ago for the dietitians, and we have been able to document our malnutrition findings in the RD assessment part of Junum. And you can see it kind of at the top of the screen. It says RD assessment at the top of the screenshot. This screen is what the providers see, and it gives them at a glance summary of what criteria the dietitians diagnose the patients with. So we're able to show on this avatar over here where the patient is showing physical signs of malnutrition in this summary tab. And the providers can also see decreased PO intake and weight loss, and it's under that little evidence button, which you see on the left middle side. Next slide, please. So phase 2 is the provider's best practice alert. So there are 3 alerts, and that's just behind the scenes in EPIC so that the BPA is always aligned with exactly what the provider needs to do. So the primary team will see the BPA fire, and the alerts pop up when the provider pulls up the orders tab. So there are 2 parts to the initial alert. One is to add the malnutrition diagnosis to the problem list, and the other is to add the malnutrition documentation to the progress note itself. The third alert fires if it was not documented in the progress note the first time around, and it is mapped based on the severity of the findings. So they will either see it as moderate or severe malnutrition, and the team never sees all 3 alerts at once. Next slide, please. So there is a link from the best practice alert that opens into the provider progress note and auto-populates the malnutrition diagnoses. So it's pulled from the already malnutrition assessment. Previously, we were using a malnutrition smart phrase so that the providers can pull that into their notes. This BPA went live in July 2024 for the first time. However, at this time, we did pull the BPA back so it doesn't fire for providers anymore, because we were just working through some tweaks we found. One of the barriers that made the EMR a little bit slower for the providers. So we just pulled it back to work through it and improve the workflow for them. Overall, right now it is still live for the dietitian, so we all think it's a lot easier to document and flow into our note templates. Next slide, please. So next steps, we always want to continue to fine tune the malnutrition diagnoses with our inpatient dietitian team and work with the quality manager to evaluate the reports. Currently, when we're trying to pull these reports right now, it's showing like double documentation in the Junum side. So our numbers are a little off, so we're working through that as well. We, of course, want to continue to facilitate high quality, comprehensive nutrition care that begins in the inpatient setting and can continue after discharge. We do always refer patients to see our dietitians in our clinics when we feel it's appropriate. We want to ensure the bridging of nutritional gaps while they're at home as well. If patients are food insecure, we do provide them with resources like we mentioned earlier. We also provide them with the handouts with local resources. And we do have a program which Dr. O mentioned, which is called the Food as Medicine program here at Grady. So when patients are discharged and they go to our clinics, they're screened again for food insecurity. And our Food as Medicine program is a program for patients who are food insecure and either have uncontrolled hypertension or uncontrolled diabetes with an A1C over 9. And it is a year-long comprehensive program for patients to receive every single 2 weeks. They get 30 to 60 pounds of fresh produce, 2 to 4 pounds of whole grains, and 2 to 4 pounds of legumes, depending on their family size. They also see one dietitian once every 3 months. They do one cooking class once every 3 months. And they also follow up with their doctor every 3 months to assess if their blood pressure has gone down or if their A1C has decreased at all as well. And from the inpatient side, when we do provide these resources to patients, one time I had a patient, he was on dialysis. I was consulted for renal education. As I was talking to him and gaining that nutrition background, that nutrition history from him, I learned that he was depressed from his wife dying recently. He didn't have the motivation to cook. He also didn't have the finances to get healthy food. And he was also fearful of canned goods because he was on dialysis and was concerned about the phosphorus content of these canned goods. So I diagnosed him with malnutrition based on these findings. And I was able to provide him with open hand meals to receive when he was getting discharged to help him transition home. And I also talked to the care team as well because he was malnourished. So I was able to provide that documentation to them. And we were all able to reiterate the fact that his focus should be on getting adequate nutrition while he was malnourished and while he was on dialysis. And that became the focus for him while he was admitted and for while he was discharged as well. Next slide, please. So overall, the GMCS implementation outcomes, of course, we want to decrease the hospital length of stays, decrease the infection rates, decrease the hospital readmission and the healthcare costs. And then we want to improve the identification of at-risk patients and improve the discharge plans that address the malnutrition. Next slide.
Thank you very much, Danielle, Dr. O, Cheryl, Dr. Phillips, and of course, Laura, for getting us started. And I'm impressed with the depth of the presentations and how much work Grady's been doing. It looks very trailblazing in many ways. And, this kind of activity will help us in our work to raise the profile of the issue of malnutrition from a policy standpoint. And even going so far as hoping that as we move toward this new initiative around making America healthy again, that we recognize the importance of nutrition in that whole initiative, but also recognizing that malnutrition as a chronic disease needs to be addressed more thoroughly and the prevention focused on more realistically. So I do have some questions that are in the chat. Let me begin with the first. Whoever wants to answer, feel free. When it comes to nutritional screening, is there a specific evidence-based tool that you are using to screen your patients?
I can go ahead and answer that.
Thank you.
Here at Grady, when patients are admitted, the nurses use the malnutrition screening tool to first assess patients. And if they hit the criteria of 2 or more, they then put a consult in for the dietitians. And then we also, all the dietitians here at Grady, we screen our patients ourselves that are admitted to our own floors. And we assess for malnutrition using the Aspen guidelines. So that's assessing for weight loss, PO intake, and muscle and fat wasting using nutrition-focused physical exams.
Thank you for that. What is a food pharmacy?
Yeah, so our food pharmacy is part of our food as medicine program here at Grady. It is a comprehensive program for patients that are food insecure and either have uncontrolled diabetes with an A1C over 9 or uncontrolled high blood pressure. So patients that are enrolled in this program every 2 weeks, they get 30 to 60 pounds of fresh produce, 2 to 4 pounds of whole grains, and 2 to 4 pounds of legumes, depending on their family size. They do a cooking class once every 3 months with our registered dietitian. They see a registered dietitian for nutrition counseling once every 3 months. And then they also follow up with their doctor at the end of the 3 months to see if their A1C has decreased at all, if their blood pressure has changed also. And in this program, we really have had great improvements for patients that are enrolled in it. We had patients that have gone with A1Cs from over 16 to A1Cs of 7 and below in just 1 year. And it's a beautiful thing to see, and the patients are always really appreciative of the produce, and it's a great program here at Grady.
Who pays for the meal delivered for 2 weeks?
Yeah, so we are partnered with the Atlanta Community Food Bank here, and it's free. All of it's free for the patients and for the hospital as well. So we get our funding through our foundation here, but all the produce for the patients are free, and then the food bank gives it to us for free as well.
Right.
Bob, if
yes.
I can add to the payment, so understanding what health plan, if they are enrolled in a health plan, for instance, Medicare special needs plans, many of them have nutrition benefits that go beyond just a 2-week post-discharge, but maybe a benefit for continuity. This is also a remarkable opportunity to look into your community, home and community-based services, whether it's senior center programs or some of the nutrition programs that have sliding scale fees based on income. So low income older adults may pay little to nothing. Know your community resources, know the health plan. So Grady's model is a fantastic one, but many of your organizations where you're at, maybe your hospitals aren't paying for food, but there may be some resources that you can tap into, both from the health plan side, the Medicaid side, and the home and community-based services side.
Thank you for that. And Laura, I'm going to turn to you for a second. I just finished doing a webinar. Since you referred to the food banks and how important they are to this particular program of yours, your Food as Medicine, we're confronting a challenge here where advocacy may be needed to restore programs that have been suspended currently that affect food banks. Laura, would you mind touching on the specifics on that?
Yes, the USDA has paused 2 programs. One that provides local produce from farmers to food banks, and one to schools. The only explanation so far is that it does not align with the current policies of the USDA. And there's another USDA program that has been paused, the Emergency Food Assistance Program, which also buys local produce from local farmers.
So let me suggest, if you have an interest in wanting to advocate to keep those programs going, go to our nanas.org website, and we have communications that we're doing, and we would welcome particularly those that have direct experience with food banks and understand their importance. As you have just articulated very well, Danielle, they play a huge role in this area, and they do impact health. It isn't just a food bank; it's way more than just a food, obviously. So we just want to make sure we threw that into our conversation. 2 other questions have come. One is, are there any best practices for the unhoused?
the unhoused population is, of course, a national tragedy and a national dilemma. There are some spotlights of remarkable interventions. There is Healthcare in Action, which is a street medicine program based in Los Angeles, which has actually several health plans that are working together, and nutrition is part of it. Again, going back to some of the senior centers and home and community-based services and the food banks. But I think the other challenge, as Bob, and I'm going to put my policy hat on, nutrition is at a core fundamental need for health. And when we ignore nutrition, we increase healthcare costs, not just for the individual, but for the state under Medicaid, and for the older adults, the Medicare program. So working as a policy voice, both at our state level and at the federal level, looking at nutritional supports. So getting back to the question for the unhoused population, it's a challenge. There are resources out there. They tend to be fragmented and isolated. And the most important thing you can do is learn to know the resources within your community.
That's true. And I think in your fair city of Atlanta, the Atlanta Regional Commission would be a wonderful resource in that area for sure. And Becky Kurtz is my good friend, and I'm sure you all know her, and it'd be a good place to go. What is the biggest barrier to implementation? What was the biggest barrier to implementation did you experience in your work toward adopting the GMCS? Appreciate any tips for engaging all the various disciplines involved.
Danielle, you want to, I think it's, well, some of it, I think the providers were willing to get on board. I think the process of, creating the flow sheets and creating the avatars in Epic and so on, a little bit of a challenge, but, it took some time, but we did implement that. And then now some of the challenges are efficiency for the providers, by the additional documentation that's needed. So Danielle, if you want to say something about it.
Yes, Dr. O pretty much said it all. We have pulled back the BPA fire so we can make it more efficient for providers. From the nutrition standpoint, for my team's end, our biggest challenge has been making sure that the data being collected is accurate. Like sometimes it shows that they have, on the genome side, it shows they have double the numbers, but it's more so of a patient being double documented on, or double, it shows up twice on their end. And so we're still trying to work out how to make sure that documentation and like data collection is accurate on both ends and that they match up. So it's still a work in progress, but we always want to improve our processes and make sure we're providing the best patient care.
And I would just add one general response. I think the biggest barrier is awareness. I think when an individual, particularly an older adult, presents into the emergency room, we're focused on the disease and the presentation, and we think about the person as the sum of their diseases. So we're focusing on care plans for each of their diseases. It is the ability to step back and recognize and think about malnutrition as an underlying contributing cause across the board to their presentations. That's a learning cycle that is why this webinar is so important and why the continued conversation about malnutrition is so important.
Thank you.
Just wanted
Oh, yes, go ahead.
Yeah, so right now, part of, awareness absolutely is very critical. So part of what we're doing at Grady is we have every 2 weeks right now, as part of our rollout, we're doing like age-friendly classes. That it's a 4-hour class essentially that includes the staff, members of the nurses, the techs, members of the interdisciplinary team. And so it includes a geriatrician speaking, the pharmacist speaking, the dietitian speaking about malnutrition. So that helps increase the awareness of some of the hazards amongst older adults and how assessments can be done, how protocols can be implemented to improve the care of the older adults. So, yeah.
Thank you for that information. Yes. I always like when people start by saying, thank you so much for this. But I am a national director at US Vets an NGO that provides high-level on-site supportive services for previously at risk for homelessness, age 55 and older with high acuity and over, who reside in PSH. I'm in the progress of including contract providers, add to our workforce, to our National Aging High Acuity Strategic Plan. Are there recommendations for JDs or feedback from the hospital side on discharge planning with NGOs that have proven to be helpful and contribute to reducing length of stay and readmission, et cetera? Very good question. Thank you for that. I don't know. Somebody's going to have to take a brave step here, I think, to try to tackle this one.
I wasn't very clear about if you could just.
Yeah, let me go back over and try it again and see. So I'm going to go to the second one. I'm in progress of including contract providers, add to our workforce, to our national aging. Actually, you know, if Megan, if you're there, can you just unmute yourself and ask the question yourself? It might be better. Can we do that, Laura?
Unmute. Hello.
There you go, Megan. Hi.
Hi, sorry. Thank you so much for this. Yeah, so I'm overseeing, I'm in California, but our national strategic plan, and we've got a lot of RAND data that has come back that we've been successful so far in reducing hospital stays, and these are veterans who are not utilizing the VA in traditional veteran medical models. So in working with community partnerships, one of our buckets is food insecurity and nutrition, and also these are folks that would have hospice in home. And so in collaborate, just JDs or what like feedback you guys have had in terms of contract providers or tips of the trade when we don't have a medical deputy in our organization, and our LVNs are also contracted. So how do we keep that in-house and be good partners to our community hospitals that we are going to be infiltrating? Well, hopefully not infiltrating, the opposite of that. Yeah, any feedback for nutrition and food insecurity and hiring roles?
Cheryl, you got a thought on that one?
No, I'm still struggling. So you are looking to hire nutrition support staff within your.
Yeah, so we have unrestricted funding to develop our workforce, and right now it's pretty heavy in the mental health side of things, and we're looking to have the other part of the disciplinary in there. And so anticipating that if we do our job, that our veterans will die in their homes in our care and not in your hospitals. Right. What roles would you recommend or have been helpful when you guys are doing discharge planning for multidisciplinary teams on the physical health side of things?
So, you know, in addition to the kind of standard social work, therapy, a clinician, whether it's a geriatric nurse practitioner, physician, someone who understands the medical side, the pharmacist, having a registered dietitian, I think, is a critical element. Danielle, I'm sure you would concur with me that that's in an interdisciplinary or multidisciplinary team. And I think there are resources within the community where these can be leveraged even on part-time or contracted on a needs base. So I'm not sure if we're answering your question.
I guess, is there even if you had recommendations for specialties, like you're saying, a geriatric nutritionist? So what would be even like key elements that their job description would include, and where you wouldn't have to have a MD who's looking over their services, that they'd be completely independent? So right now we have occupational therapy, and they're geriatric occupational therapists, but you know, they're reporting to me, which is completely outside of their scope. And so how can we continue to use our infrastructure from a contract side?
Where are you based, Megan, in California?
We're in Southern California, is where I'm at right now, but we have 18 different housing sites across the country.
Okay, let me make a suggestion. Why don't you type your contact information in our chat and let us do a little digging for you, see if we can suggest anything or make some contacts for you.
I appreciate that. Thank you so much.
Thank you for joining us today. Next question, do you have a dedicated pharmacist for older adults or do you use order set?
We do both. We do have a dedicated pharmacists on the units where we care for older adults. We have like a medical acute care for the elderly unit and surgical acute care for the elderly unit. And so we have the pharmacists on those units and they participate in the interdisciplinary rounds, review the patients, review their medications. We also created order sets, but for all older adults across the health system, either admitted to medicine or admitted to surgery. And part of what we did was we took out some of the high-risk medicines on the order sets, and then we pre-checked things like mobility, added things like delirium protocols, added, insomnia, bowel regimen, and all that. So that's part of what we did for our order sets. So that affects or that order set is used for older adults, whether they're admitted to the ACE unit or not, since the ACE units are limited. So that was our way for making sure that across the health systems, wherever the older adults were, they got at least that, basic level of care.
Thank you. Thank you very much. I don't see any other questions that have come. I would use this opportunity to ask each of you for any closing thoughts that you might have, beginning with Laura.
Well, thank you everyone for coming to this webinar today. Thank you to all the speakers. I know that I learned more. It was really helpful to, see all the steps that you go through and the an electronic health record. I know I speak for many dietitians that that's a real stumbling block, is how to document and make sure that that patient's actually cared for. And I ask everybody who's in the audience that if you have any further questions, you'll get an email with our contacts and you are welcome to follow up with us. We hope that in this webinar that we can make new connections, in this, so that we are connecting the hospital to the community and sharing and spreading all of that best practices. And with that,
All right. Well, before I go to your colleagues, I have another question that just came in. Are there nutrition order sets for transitions of care? I'm thinking that dietitians are typically not present at all on all discharges. Sorry if I missed this in the screenshots, and thank you for this wonderful information. Anybody want to take that one?
I can take that one.
Thank you.
Yes. So we are able to provide referrals for outpatient dietitian services through Grady. Like we have a lot of outpatient clinics that we have dietitians at. So usually I'll tell the doctors to put a referral in whenever I deem it's necessary, or even if the patient just wants more education, more in-depth one-on-one counseling sessions, and then I'll message that dietitian at that clinic to have it on their radar that I'm recommending a patient for them, and it'll go into their own referral queue. And then in the geriatric unit that I'm a part of, we have a discharge planning every single day. And in that meeting, we do go over the 5 M's of malnutrition. In the meeting is pharmacy, myself, case manager, social workers, Dr. O is usually there, or another geriatrician. We usually have a different unit medical director on as well. We have our charge nurse, the unit medical nurse as well, who's on there. And the nurses come in and present their patients. So we do go over discharge planning in that meeting too. So usually I'm aware of what's going on with my patients every day, and I'm able to provide appropriate discharge recommendations or transition of care recommendations as needed in that meeting too.
Thank you. And Danielle, since you're on the screen, any closing thoughts from you?
No, I really think malnutrition is a prevalent problem that we have, and it's really amazing to see like all of us so passionate about addressing malnutrition, especially in the geriatric population. And we can only continue doing great things for these patients. So
Thank you. Dr. O?
Yeah, so I think it's taken a while for me to realize the importance of malnutrition, and it's something that we have to continue to advocate for. It's like Dr. Phillips said, the focus is really usually on the CHF and the UTI and, pneumonia and so on, not realizing how much this plays into the overall outcomes of the patient. So advocacy and improving ways to make sure that there's much awareness amongst providers in general about the importance of malnutrition, I think is key. Yeah.
Thank you. And Dr. Phillips?
Oh, thank you. So yes, I think we're really on the cusp of a transformation of healthcare for older adults. And as I've articulated, the 4 M's being very simple, easy to implement, and focusing on what is critical for the underlying care. So looking at improving care for older adults across settings using the age-friendly approach, and embedding in that the recognition, as we started out by saying, malnutrition won't be addressed if nobody is thinking about it. So do you have, as part of your assessment upon presentation, a screen for malnutrition? And the MST is probably the easiest, most widely used, most practical tool to, and it can be utilized by any of the clinicians that are first interacting with the individual patient in front of you. And then my last closing comment is, as we have talked about, once the person leaves the hospital, what are the resources that they can connect with? Are there community centers that have nutrition programs? Are there other benefits that maybe the individual may not be aware of under either their state Medicaid or their health plan? And are there food bank services that are accessible to them? So knowing what's in your community as part of that prescription of discharge of ensuring that nutrition is still forefront for that older adult.
Thank you very much for that. So on behalf of the Defeat Malnutrition Today Coalition and the John A. Hartford Foundation, we thank you, our speakers, our questioners, and our audience for joining us today. Hope you benefited from it. I know we did, and wish you the rest of a good day. So take care, everyone.